Today's discussion will really focus on two key issues that I know every governor spends a lot of time thinking about and working on. First, given demographic changes, rising costs of health care, and a range of other factors, how can we expect the U.S. health system to evolve over the next decade? For all of us, I'm willing to make the safe bet that health care costs are a major factor in our budgets and a major part of our jobs. Second would be how can governors harness these forces to improve health care in their states, also while reducing the financial burden for state governments, for our employers, and our families. Whatever changes may be on the horizon, we can be certain that governors will be dealing with them because, again, a lot of what we do has to do with dealing with health care. In Tennessee, we recently launched a statewide initiative to better reward patient-centered, high-value care. Over the next 5 years, the Tennessee Healthcare Innovation Initiative will shift a majority of healthcare spending, both public and private, away from fee-for-service to 3 outcome-based payment strategies. The first is an episode-based strategy that aligns financial incentives to promote successful outcomes for a discrete event, such as a joint replacement or pregnancy. The second strategy focuses on primary care transformations that encourages prevention, coordination of care across providers, and involves the physician in the management of total cost of care for their patients. The third incorporates other value-based payment approaches that will reward quality of care for long-term services and supports providers as well. With these efforts, it's our hope that Tennessee will be at the forefront of a national trend that is expected to gain momentum in the coming years. Many governors are implementing or considering similar statewide multi-payer initiatives to help move from fee-for-service to a system that rewards value over volume. The federal government is supporting many of these efforts through the State Innovation Models Initiative, or SIM initiative. Tennessee received a Model Design Award in the first round, and in the second round will compete for a Model Testing Award to support implementation of our State Innovation Plan. Despite SIM and other federal efforts to support state-led innovation, successful statewide transformation will require a new era of collaboration between states and their federal partners. This enhanced state-federal partnership is a key for states to continue moving the needle toward higher quality, more efficient care, and better health status. To this end, at the last NGA meeting in February, governors approved a series of recommendations developed by the NGA Healthcare Sustainability Task Force. Governor Kitzhaber of Oregon and I had the privilege of leading that task force, and it's worked with the administration on a number of key issues. Those include streamlining the federal process for reviewing state innovation proposals, creating a path to permanency for successful state programs, and allowing states to share in federal savings resulting from their efforts. Achieving these and other goals outlined in the task force report will give states the flexibility and the resources they need to transform their healthcare systems and respond to the future challenges and opportunities we will be discussing today. I would like to turn now to the Vice Chair of our committee, Governor Shumlin, for any remarks that he may have. Governor?
Well, thank you, Mr. Chair. Thank you, fellow governors. Looking forward to hearing from the panelists. I got to say, I don't want to get myself in trouble here, but I got to say this has been the most fun, successful summer NGA meeting that I've ever been to, and I bet the other governors agree. And last night's entertainment show was just one other example of how you're getting this right. So thank you for everything you're doing, Governor Haslam, for the NGA, for all of us governors. And it's going to make it tough for any of us to host future summer meetings, so maybe we'll just shut them down from here going forward. Listen, I want to thank you all for being here. Governor Haslam is doing extraordinary work in Tennessee. This is an area of health care where we all agree that we've got to get costs under control. And today's discussion is really critically important to the work that governors are doing around this table and around the country, leading in our states. And when it comes to health care, we're all working to stop skyrocketing costs and that are hammering businesses, hammering job creation, hammering middle-class working families, and threatening our ability to invest in other priorities such as education, roads and bridges, public safety, job creation. I know in Vermont, as an example, and this math always is probably no different in other states, today Vermonters spend 20 cents of every dollar they make on health care on average. And if we were to see health care costs rise just for the next 10 years, at the same rate that they did for the last 10 years, that number would double. What I often say to Vermonters is, raise your hand if you think that that's a prescription for job growth, for economic prosperity, for a great future for all of us. So healthcare cost is where it's at, containing cost. As Governor Haslam just noted, there's broad alignment among the stakeholders that outcomes-based payments, moving from quantity to quality, is the wave of the future. And we governors are prepared for potential challenges that lay ahead, from a rapid aging population, as the governor just mentioned, to increased consolidation of our healthcare industries that we're seeing in all of our states. There are many other trends that have implications for healthcare transformation in our states. In Vermont, we're focused on containing cost by covering healthcare providers and payers with funding from the State Innovation Models grants, which has been a huge help to us. We were one of the states that got a SIM grant. So just for a second, imagine a healthcare system where healthcare providers, everyone in the system, our docs, our nurses, our hospitals, all the other ancillary services, are totally driven to keep you as healthy as you possibly can, as they possibly can as a team, and don't have to use as many expensive healthcare services to achieve those goals. Second, imagine a system where providers have the healthcare records at their fingerprints in an IT system that just can't be beat through American innovation, and they're there when they need them. And third, where providers work with people outside of the healthcare system to make sure you have the support you need to stay healthy once you're moved back into your communities, into your homes, such as good housing, good nutrition, active preventative care. I often say eating good Vermont-grown food, all the things, getting off the smokes, exercise, all the things we know we should be doing. The innovation project.
Does maple syrup help you that much?
Maple syrup is definitely the sweets you want to use, and it's got to be Vermont syrup. That's important to know. The innovation projects support three kinds of work. The first is changing provider payments so that we pay for outcomes of care, not volume of care. That's going to be a major transformation in our system, and where we reward providers and patients for achieving that, for doing the right thing. Second, we're completing build-out of healthcare information systems that I just mentioned that link our providers together. And third, designing a statewide system for how we target and coordinate services to keep folks getting better. So how do we achieve, what have we achieved so far in Vermont in our innovation project? We've created shared savings programs for providers. The obvious question is, how do you achieve this model? How do you move from the model of payment we have to the new one that goes forward? Shared savings programs are the first step away from volume-based payments for healthcare providers towards value-based payments. We've launched one program for Medicaid and one for private insurers. Vermont's the first state to launch that kind of program on a statewide, all-payer basis so that everybody's in. We've got our healthcare providers, our hospital execs, everyone around the table trying to figure out how to get this right. We've also invested grant funds in healthcare information technology, as I just mentioned. Continued build-out of that interface between healthcare providers and the state's healthcare information exchange system is critically important. That includes establishing connections between hundreds of healthcare sites across the state. We all face that challenge as governors. And finally, building an electronic gateway that will route healthcare data for quality reporting, care management, and improvements to patient care. We have all of our major payers and providers in the state talking about collaboratively a common approach to healthcare improvements. Everyone knows that the healthcare system won't be affordable or effective unless we focus clearly on keeping Vermonters healthy. So for all of we governors, first priority is quality of care, keeping our people healthy. Second, right now, everyone's taking their own approach to healthcare improvements, and that's what we need. We need an all-out coordinated effort across the state. And finally, this is what we're building in Vermont. So I look forward to the presentations that we're going to hear from the other folks on this panel, the other comments of the other governors. I really do believe that the governors working together in a bipartisan spirit with the states as the models for innovation and change in healthcare is where the rubber's going to hit the road in bringing about affordable quality healthcare that allows us to spend more money growing jobs, investing in infrastructure. Thank you so much, Governor Haslam, and I'm delighted to turn it back over to you.
Thanks, Governor Shumlin. Let me introduce our distinguished guests. We have a great panel here today, and what I'd ask all the governors to do, if you can hold questions till the end of their presentations. We're going to set aside a good chunk of time for question and answers at the end, so I would ask you to hold those questions for then. Let me begin by introducing Tom Latkovic. Tom is a director at McKinsey & Company who has spent over 13 years there working to improve the performance of the U.S. healthcare system. Tom leads McKinsey's payer sector in the Americas and co-leads the firm's state and local government practice. He also founded Healthcare Value Analytics, a special division within McKinsey dedicated to supporting, designing, and implementing payment and delivery system innovation. Tom, welcome.
Thank you very much.
Also with us today is Andrew Dreyfus, Chief Executive Officer for Blue Cross Blue Shield of Massachusetts. Prior to becoming the CEO, Mr. Dreyfus spearheaded the development of the company's Alternative Quality Contract, one of the largest commercial payment reform initiatives in the country. Mr. Dreyfus also previously led the Blue Cross Blue Shield of Massachusetts Foundation and the Massachusetts Hospital Association, and he held numerous senior positions in Massachusetts state government. Welcome, we're glad to have you with us.
Thank you.
Also found out his son is an aspiring singer-songwriter, so you're in the right place. Finally, I would like to welcome Bill Rutherford of the Hospital Corporation of America, or HCA, as they're known here, one of Tennessee's and the nation's leading providers of health care services. They're based here in Nashville. During his 24-year tenure at HCA, Bill has served in a variety of roles, from staff auditor to chief operating officer of the Clinical Physician Services Group to his current role as chief financial officer and executive vice president. In 2005, he took a brief hiatus from HCA to start his own training and education company, and then served as chief executive officer of the behavioral services provider, Psychiatric Solutions. So with that, Mr. Latkovic, I will ask you to lead off for us.
Thank you very much, and very much appreciate being here with you today. As Governor Haslam shared, I'm a partner at McKinsey & Company, which is a management consulting firm probably better known for our work in the private sector, working with many of the leading healthcare companies in the world. But we also do quite a bit of work with governors and with states across education, economic development, technology, et cetera, and are working with a number of states on healthcare payment innovation, Medicaid performance improvement, technology, et cetera. So today, my perspectives I'll share will be both from our research as a firm as well as my personal experience working in both the public and the private sector. I should also clarify that we're not a political organization. We're pretty much nerds. And we come at things from an organizational, and operational, and a technical standpoint, but not from a political one. So none of my comments today will be referencing any specific policies or pieces of legislation, including the Affordable Care Act. And in many respects, what I'd like to do is take a step back and actually make a bit of a case for the kind of initiatives that are going on in Tennessee and Vermont. And there's really four things I'd like to share with you today. One is I think we have a unique time and opportunity to fundamentally change the trajectory of the healthcare system in this country, and that's very exciting. I think the next 5 years are going to be critical for the next 25. But those improvements, that change is going to be quite difficult. Second thing I'd share is we think that the performance of each state's healthcare systems could quite likely diverge over the next 3 to 5 years. Some states will be on more of a success path, other states may not. Third, I'd argue that governors and states' actions and inaction will be very consequential, not just in the public sector, but also the private sector. Another way of saying that is I think there's a huge opportunity for what states do and what governors do to encourage, enable, and accelerate private sector innovation. And fourth, I would argue to be on the success path, several shifts are going to be necessary, both from the private sector but as well as the public sector. Shifts in agenda, shifts in capabilities, and shifts in governance. So to start with, and I am a consultant, so I did come with two charts, although two is pretty good. So I won't belabor the point, but despite its many strengths, there's an enormous and well-documented opportunity to improve our healthcare system. There's a number of studies and analyses, including some done by McKinsey, that would suggest that hundreds of billions of dollars, we spend hundreds of billions of dollars more than we need to for the outcomes we get. That's true across Medicaid, it's true across Medicare, and it's true across the public sector. In fact, last year I published a paper called the $1 Trillion Prize, documenting how intelligent changes in our payment system could literally lead to saving $1 trillion over the next decade. Now, in the face of that opportunity, which I think there's pretty strong consensus for, we're experiencing a number of real discontinuities or massive forces affecting the system, some of which were mentioned. Increasing prevalence of chronic disease, a proliferation of technologies and data, growing provider specialization, increasing role for consumers, and across all of this, an affordability crisis with consumers, with employers, and with taxpayers. So by the way, these forces were all in play prior to the Affordable Care Act. They're all going to be in play regardless of the fate of the Affordable Care Act. If harnessed effectively, I believe these forces present a huge opportunity to capture the opportunity in front of us. However, if ignored or addressed ineffectively, it could actually make things worse. So the challenge is harnessing these forces is actually quite difficult. It won't be easy. There's a great many stakeholders in the healthcare system. It's extremely fragmented. And that brings me to my second perspective, which is that we anticipate even greater separation between states with high-performing health systems and those with less well-performing health systems. Well, why do I say that? Because the innovation that's needed ultimately will play out at a local level. It will depend on the actions and behaviors of literally thousands of physicians, hospitals, mental health professionals, managed care companies, employers, consumers, et cetera. Some stakeholders and communities are going to make change more effectively than others. So allow me to be a bit more specific. I'll just highlight a few areas where I think there's a lot of consensus, not exactly on how to do this, but what the elements of success include. One of those factors on a success path is that there's productive competition amongst stakeholders, both providers and health plans, that encourage greater value. The key here is to ensuring that the competition is actually based on what matters to both consumers, employers, and other purchasers. On a failure path, productive competition is limited because few purchasers or competitors actually understand performance in ways that matter. Second thing, to comments earlier, on a success path, I think healthcare providers will be rewarded for delivering better outcomes at a lower cost. On a failure path, we'll largely continue to pay providers for activity. And last example, I think on a success path, most consumers would have adequate both insurance and savings, agnostic of the approach we use to get there. So the good news is that I think that states or communities that get on and stay on this success path actually have a real opportunity to experience moderated healthcare cost increases more in line with inflation, including in the Medicaid program, will experience greater economic growth and greater productivity and well-being of their citizens. So in other words, I would say being on this success path has a really strong return on investment, to use a business term, both for states directly in terms of their budgets and Medicaid, as well as in a broader societal sense. So if much of the actual change will occur in the private sector, why do I say that governors and state actions will be so consequential? Well, the obvious part of that is that states influence regulation, they influence infrastructure. Those things have a profound effect on how the private sector operates. But what I would call out is the state isn't just a referee in healthcare. It's an actor. And so I think there's a two-way linkage between the actions the state takes as a healthcare participant and the private sector that may be underappreciated. Just as an example, Medicaid spending is in large part a function of the performance of the entire delivery system in a state. It is incredibly difficult for a Medicaid program to sustainably improve from a cost standpoint without the delivery system in that state fundamentally improving its performance. That includes physicians, nursing homes, mental health professionals, et cetera. And it's incredibly difficult, if not impossible, for those providers to change and improve their performance only for Medicaid enrollees. Thus, Medicaid enrollees and private sector enrollees are inextricably linked together from a performance standpoint. So in that way, the two interact. So let's assume you want to be on the success path, right? That sounds a lot better. And let's assume you buy the argument that states can make a positive difference both in public sector programs, but as well as in accelerating private sector innovation. What can you do? A few suggestions here at a high level. The first is, I would argue, to start to measure success based on what you influence as governors and in states, not on what you directly control, and from the perspective of citizens and employers. For example, did employer premiums go up or down last year in your state? Did people get healthier or not? How many healthcare-related bankruptcies were there in your state? Are patients more or less satisfied with their healthcare? Second thing would be to shift focus a bit on enabling and accelerating private sector innovation where most stakeholders agree what's required, but needs some help getting over the hump, especially given how fragmented the system is. One of those areas is performance transparency, which is fundamental for productive competition. Another has been mentioned is payment innovation, or leading the transition of all payments from fee-for-service to outcomes-based payment. It includes episode-based payment, capitation, a number of different models. Most healthcare stakeholders, by the way, agree that that's the right direction to travel, but it's really difficult to get done without a critical mass of both payers and providers agreeing on the way to do it, which is why the efforts in Tennessee and Vermont are so terrific. Another area of consensus is that we need better healthcare infrastructure, both human capital and technology. And lastly, I think there's an opportunity to encourage widespread, efficient, and optimal levels of both insurance and savings. The other thing to consider just in the way of doing that is, I think, to consider the influence of the state in healthcare beyond regulation specifically, both as a convener of the private sector and other stakeholders, as well as a purchaser in Medicaid. And so the question there is, both in Medicaid and in providing benefits for employees in a state, are those programs designed and managed in a way to put you on the success path, a way that's neutral to it, or a way that actually causes it to be more difficult? And the last thing I would say is, along with shifting focus and the way you influence things, I think affecting this change will actually require adapting your governance model with even more integration across the various agencies that affect healthcare and its programs. Another way to say that is, who's accountable within each state, in your states, for overall healthcare inflation? Not the Medicaid budget, but overall healthcare inflation. Is there such a person? And lastly, I think you'll need to either develop or partner to get stronger capabilities, both with perhaps a stronger view from a private sector standpoint, as well as people that really understand these models, healthcare technology, and large-scale change, which I think is a pretty different skill set than running and administering a program. And the last thing I'll say just in a few seconds here is a couple very tactical things. Who's on point for this in your administration? Name somebody. Invest a little bit of time learning what's going on. I mean, I think my observation is the last couple of years, there's been more activity and innovation and difference at a state level than there has been for a long time. So I think there's a real opportunity to learn what's working and what's not from other states, more than there has been. I'd say get some real facts on your state, not just on state programs, but the whole healthcare system, and use that to build a real action plan. And the last thing, a number of states are participating in the state innovation model, a number aren't. So I think we agree that can be a really strong catalyst for the type of change that we're talking about. So thank you.
Thank you, very helpful. Mr. Dreyfus? Yes. We'll let you bat second.
Great. Thank you very much. You know, the most important point that I want to make to you was actually made by Governor Haslam and by Governor Shumlin when they spoke, because you have governors from two very different states geographically, ideologically, and in terms of their healthcare markets. You know, they say, well, you know, but they both focused on the same solution: to change the fee-for-service system to an outcome-based, value-based system as central to the solution for both improving care and promoting affordability. And I'm going to tell you a very short story about how Massachusetts over the past 5 years has done just that and what some of the results have been. Before I do so, you might step back and say, is the experience of Massachusetts really relevant to our state? After all, aren't you a deep blue state with one-party rule, unified on your progressive views of social and other issues, and in a healthcare market centered on large academic medical centers? Well, what I tell you is we're actually a much more diverse state ideologically, politically, and in terms of our views of markets than you might think. And so there are some surprises in our story. From the diverse views within our state, we actually have forged the kind of consensus that the governor spoke about. And in doing so, we've tackled some of the thorniest problems in healthcare. And we've done it by balancing these issues that we just heard about, is the role of government versus the role of the market. How do you balance those two? How do you constantly recalibrate those two forces? And how do we make sure that the market can continue to innovate? So let me tell you about what we've done in that respect. I think you probably mostly know the story, the progress we made on healthcare coverage. And so we passed our version of the ACA back, signed by Governor Romney in 2006, implemented in 2007. So what the nation's experiencing in 2014, we experienced back in 2007. And as you can see, a dramatic reduction in the number of uninsured in the state. The number's even lower now. There are no uninsured children in Massachusetts today, and just a very small number of uninsured adults. But we had a second problem. We had a cost problem. Some people say, well, on the coverage issue, you started from a stronger point. We started from a weaker point here because we are the locus of the most expensive healthcare, not just in the country, but perhaps in the world. So we had a lot of work to do on cost. And so at our plan at Blue Cross Blue Shield of Massachusetts, we stepped back in 2007 and said, how do we tackle the cost problem? And our answer, as the governor said, was to fundamentally change the way that we pay physicians, hospitals, and other health caregivers that moves us away from our volume-based, activity-based system towards one that rewards quality and outcomes. We did it, we designed our own system. It is not the solution, it is a solution, but it has proved both surprisingly popular and surprisingly productive. So we started with what you might think of as a pilot or a demonstration project in 2009. We had about 1,500 or so physicians covering about 300,000 of our members in Massachusetts agreed to accept, rather than fee-for-service payment, a global payment for each of the Blue Cross members that those physicians cared for, combined with very significant quality incentives, not just a little point or two of pay for performance, but up to 10% on top of what we paid them they could earn if they perform well on a set of agreed on quality incentives. No black box sitting back at Blue Cross. These are transparent incentives that are nationally recognized. These were voluntary contracts, but we rapidly were successful, and very quickly, almost 90% of the physicians in Massachusetts now accept this form of payment. It covers about 700,000 of our members, making it the largest, or one of the largest payment reform initiatives in the country. At one point, our own governor, Governor Patrick, asked me, he said, Andrew, how can we move this even faster? And I said to him, with all due respect, Governor, it's not going to be elected officials or certainly health plan executives who are going to persuade physicians to change something they've been doing for 75 years. It's going to be other physicians who say, I can take better care of my patients under this system. And that's what they started saying. Now, this is not only the largest, it's also the most carefully evaluated payment reform initiative in the country. So from day one, a team of independent researchers, health economists, and physicians at Harvard Medical School were hired by the Commonwealth Fund to evaluate it, and they published in the New England Journal of Medicine, Health Affairs, and other academic publications the results that showed us approaching what I think we all think of as the holy grail of American healthcare: better care at lower cost. We have the first 2 years of results. Years 3 and 4 should be published this fall. I'm not allowed to talk about them because they're not yet published, but I'll just tell you I'm happy about them. So what else did we do? So not only did we ask physicians and hospitals to change what they did, but we had to change. Governor Shumlin talked about part of the solution is having data at the fingertips of the practices, so we put that data at their fingertips. I don't expect you to look at this. These are just a sample of some of the dashboards and benchmark data that we gave to physicians. Some is as simple as saying, did you know your patient was admitted through the emergency room to the hospital last night? Many doctors don't know that unless they're on a system. But a lot of it is much more about, did you know how your diabetic patients are faring relative to other diabetic patients in similar practices around the state? Here are some ideas about how you can get better, not prescribing them from our perspective. And what happened when the physicians started looking at this is they started changing the way they provided care to their patients. One of the leaders of our large physician practices talked to me about, we're going to get liberated from the tyranny of the office visit. We've constructed our healthcare system for 100 years around the office visit, and obviously it can many times very important. But most healthcare takes place between visits. So what are we doing between visits? So what do these practices start doing? They start hiring social workers, embedding them in the practice to deal with their patients who have mental health or family issues. They start sending pharmacists out to people's home to look in the medicine cabinet to see, are there drug-to-drug interactions? They start communicating with their patients online through telemedicine, through a whole variety of different efforts. And they like practicing better. And as a consequence, we now have close to half of the physicians in Massachusetts are accepting this form of payment, not just from us, but as you heard, you need all payer solutions from our other private payers and increasingly from our public payers. I should also say this works in rural practices. Yes, there are rural parts of Massachusetts. Urban practices, practices that serve low-income patients, practices in the suburbs, practices affiliated with large academic medical centers. But I said it's not just the private sector, it's also government. And so in 2006, we passed our healthcare reform law, but every year, every 2 years after that, our governor signed a cost containment law. And each law started to ratchet up the pressure. Until 2012, we passed a law that Governor Patrick signed that actually says state health spending in Massachusetts shall not grow any faster than the overall state's economy. And you probably know we've been growing at about double that rate. But it's not government that's really going to enforce that law, it's really the private sector, back to that balance between innovation and government involvement. And just finally, I think repeating some of what you heard, what can states do? And I served on the University of Virginia Miller Center's panel, co-chaired by 2 governors, 1 Republican and 1 Democrat, that looked at these issues. I encourage you to look at those results. Convening a broad-based conversation within your state on cost, quality, and value, promoting the kind of innovation and experimentation that we're hearing about both in Tennessee and Vermont, investing in prevention and wellness. We haven't emphasized that as much, but I know, Governor Haslam, you have a wellness institute that you've established and worked hard on. And obviously, Governor Shumlin has done so much on the chronic care issue. We know that 5% of our patients are driving half of our spending. They're almost all people with multiple chronic illness. And then understanding technology and the key role it can play. And so, again, from what appears to be a single deep blue state, we actually have had a diverse experience of market innovation, balanced with government involvement, resulting in a dramatic drop in the rate of growth in healthcare spending and a dramatic improvement in healthcare quality that's been embraced and supported by the physician and hospital leaders in Massachusetts. Thank you very much.
Thank you. Bill?
Thank you, Governor. Good morning, everybody. My name is Bill Rutherford, and I am the Chief Financial Officer of HCA. It's my pleasure to be with you this morning. I'd like to spend just a few minutes sharing with you our perspective as a provider of what we're seeing with the healthcare landscape across the country and 3 key observations. You may know HCA is the largest non-governmental healthcare provider in the United States. We operate 165 hospitals, 115 surgery centers, have a network of over 35,000 affiliated physicians. We operate in 42 markets across 20 states. Annually across the HCA system, we'll see 7 million emergency room visits, deliver 250,000 babies, have 1.7 million inpatient admissions. 80% of our hospitals have been recognized as top performers by the Joint Commission. And historically, about 8 to 10% of the patients we care for have had no health insurance. In essence, we account for about 4 to 5% of all hospital care in the United States. So we think that gives us a fairly unique perspective on the healthcare landscape. We see more healthcare than just about anyone across a range of diverse marketplaces. So I wanted to share with you some observations of what we're seeing. Clearly, what's dominating the discussion in our industry is health reform, efforts to help people gain access to care, and delivery system reform improvements that we've heard about this morning. Those efforts are clearly continuing to unfold, but we are encouraged with early signs that we're seeing with the impact of that across many of our markets. When we reviewed our first quarter results, we have about 5 states across the HCA footprint that had elected to expand Medicaid. In those states, we actually saw about a 30% decline in uninsured activity as those individuals gained access to care either through Medicaid or through the health insurance exchanges. When we look across the broader network and look at the activity with health insurance exchanges, about a third of those patients are newly insured or that they were previously uninsured. So momentum is clearly gaining on those efforts to help people gain access to care, and we think those are positive developments. So I'd like to share with you really 3 key observations based on our experience across the marketplace. The first one I'll share is HCA and provider systems we see across the market are investing heavily to create what I'll refer to as high-value integrated delivery systems. And there are certain characteristics of these delivery systems that are important prerequisites for preparing for changes in the evolution of care and reimbursement methodologies. Obviously, continuing to advance key quality initiatives and focusing on improving health outcomes. Focusing on collaboration and integration of what historically, and largely still is today, a fragmented delivery place between hospitals, physicians, and various ambulatory settings. We are investing heavily in technology, on electronic health records and other integrative platforms that will allow data to transition through the continuum easily. A continued focus on reducing the cost of healthcare that we talked about today. That's either through consolidating of administrative services, reducing variation, sharing best practices, and a host of other efforts. And importantly, continue to focus on improving the patient experience as they navigate the healthcare system. All of these efforts are, in essence, is to bring together a hospital network, a physician network, and an outpatient ambulatory network, tied together with technology, all in an effort to improve health value, to improve outcomes over cost, while improving the patient experience. What we believe are three key ingredients for success and prerequisites as changes in the healthcare system occur. The second observation I'd like to share with you is although payment reform and value-based purchasing is garnering appropriately a lot of attention, we see those models being implemented relatively slowly across many of our markets and in varied form. There are clearly new payment models being introduced by both governmental entities and commercial entities. We have new pay-for-performance metrics in many of our payer relationships that largely provide incentives for the achievement of certain quality or other objective measures that we heard about in Massachusetts. And we think those will continue to progress in the market and are important as we continue to look at delivery system improvement. We think it's really a prerequisite and necessary for providers to continue to strengthen their delivery system capability through integrating, through technology, through focusing on cost, and improving the patient experience are all important success factors that will survive and be important under an array of different payment mechanisms that might be in the marketplace. And lastly, the third observation I'll share with you, as you may know, there are still many administrative and regulatory hurdles that likely will slow the pace of some of that evolution and integration in the marketplace. You know there are many regulations that govern the relationships between hospitals and affiliated physicians. And as we search for ways to provide incentives and align key objectives, oftentimes you have to set up administrative and complex structures that require time in order for evolution to see in the marketplace. We also know there is a lot of administrative cost within the healthcare system. The advantage of HCA is our scale, that we're able to leverage our scale across that, continue to work on reducing those costs. And many of those, and oftentimes can be argued, are redundant between payers and providers. So continue to search out how to reduce some of those administrative costs. We agree is a really important component of the future of healthcare. So in summary, it is an exciting time. Health reform, efforts to help people gain access to care are going to be important developments in our marketplace, and we are encouraged with early signs that we're seeing with that. Health systems across the country are continuing to invest into creating these integrated delivery systems, bringing hospitals and physicians together, investing heavily in technology to be able to transport data and information that will help reduce the cost structure. Payment reform is occurring. It's unfolding at varied pace, at a little bit moderate pace across the country. We think that will continue to accelerate and will be an important component for delivery system reform improvement. And there still are administrative and regulatory activities that are real and operationally that we have to deal with as we think about evolving the marketplace that will facilitate our move to the next generation of healthcare. So my pleasure to be with you this morning, and I look forward to questions or other discussion points. Thank you, Governor.
Thanks, Bill, Tom, and Andrew. And I'm going to open up for questions from the governors. Let me ask the first one. And Andrew, you talked a little bit about this. I think we all see the reality that health care costs are driven by folks dealing with chronic disease or at end of life. And as we talk about payment reform and moving away from fee for service, how does the fact that the cost is, I don't know what somebody here might know. What is the cost of those two? I think you said that.
Well, chronic care, 5% of our members and the residents of your state probably account for about half of the healthcare spending, and the vast majority of those have chronic illness, multiple chronic illnesses.
So if you add the chronic illnesses to end of life, you're talking about a really big
Yes.
chunk of what healthcare is costing us. So given that, as we talk about payment reform, fee for service, given those two realities, how does fee for service impact the world?
Well, let me start on the chronic illness side. So almost the first thing that physician practices do when they're given a different set of incentives is they focus on those patients with chronic illness, because those are the patients who they see the most, who are hospitalized most regularly, and most of the time those hospitalizations could be prevented if the patient's chronic conditions were managed more effectively. I actually sat earlier this week with a practice from California that has eliminated admissions for their patients with congestive heart failure because they have a payment model like this in which they're monitoring the patients in the home, scales, electronic scales tied to the physician's offices, making sure the medication interactions are working appropriately, having a lot more home-based care, and this is something common to both end-of-life care and chronic illness, is trying to move the care out of the hospital. With all due reference to our hospital representative on the panel, I'm sure he would agree that we only want the patients in the hospital who must be there. And most patients with chronic illness, you can avoid hospitalization, and then if they are hospitalized, to prevent them from being readmitted to the hospital. And so there's a huge opportunity there. Many patients with chronic illness also have a psychiatric or mental health diagnosis, and managing those much better. We know that patients with a chronic illness with a mental health issue will consume a lot more healthcare services. So getting the clinical team focused, and I say clinical team because healthcare is moving from an individual sport to a team sport. And as a team sport, it's nurse practitioners and physician assistants and pharmacists and social workers and care managers who are making the difference with these patients with chronic illness. My mother had a whole variety of chronic illnesses, and she would often call her physician up, and she just had a little question about a symptom she was feeling. He would say, "Come to the office and see me, I'll take a look." She didn't need to be seen. She needed someone to say, "Mrs. Dreyfus, let's change your medication a little bit," and that would have helped a lot, saved the system a lot of money. So it's a great opportunity and a great question.
No, I think it's a great question from my view. I think, it deals with this concept of evolving from an episodic provider of care to managing a care, and that's most prevalent when you look at chronic diseases. And I think there's really, as I mentioned, some prerequisites, is you have to bring that system of care together because, as you mentioned, requires a lot of different settings within the community. Your primary care physician, outpatient settings, specialists, hospitals, post-acute, and a lot of other activity. So the first effort, I think, is to be able to collaborate what in many communities today is still a fragmented delivery system. So investments in technology to be able to transport data across those different continuums and provider settings is, I think, a very important prerequisite to occur. I think creating structures that allow, flow of information and other information to flow among so we can better manage those patients for the right condition.
Other questions from Governor? I can keep going, but yeah.
Thank you. My question is for Mr. Latkovic. You mentioned in your presentation you thought one of the essential first steps toward moving toward quality of care payment based on outcomes versus services performed was a transparent, fact-based measures. And could you give some examples of some fact-based data systems that the public could see?
Sure. It's a great question, and I think there's two things I mentioned. One is simply there's some overall healthcare statistics in a state like premiums or health status, things like that are useful to track. But in terms of what will help actual providers make better decisions or compete on value, or what will help consumers that are trying to make a decision about which healthcare provider to go to, I think the trick is most of the data that's provided today is similar to the way the system is structured today. And so as Bill described, in any, for example, episode of care, let's say you have to get your hip replaced, or it's an elective surgery of some sort, there could be a dozen or more different providers that you interact with over the course of that episode of care. And today, even the data that's released typically even if it exists, in which most cases it doesn't, but if it does exist, you might get a little glimpse of each of those 10 providers. What you don't get a glimpse of is any sense of, particularly the surgeon that's doing the surgery or the hospital where you do it, how does their performance look in terms of that entire episode of care? So that would be a slightly different way to share transparency. Another example would be, as Andrew described in their model, if you have a primary care physician or primary care team that is historically would just see you in terms of office visits. As a consumer, you actually, you almost have no way to know which of those teams or individual clinicians will do a better job in helping you manage your chronic illness or a worse job. At best, you might get a little bit of fee information on them as individual providers. And so the real trick, again, with the performance transparency is not just the data itself, but however it's accomplished, whether it's private sector or public sector, framing it in a way that's actually usable for consumers, employers, et cetera.
So let me follow up on that, Tom, and picking up on something Andrew said, where Andrew, you said it's moving from an individual sport to a team sport. So if I'll take that analogy and play with it a minute. So you're moving from playing baseball, where you're up at bat, or the ball's hit to you at shortstop, to you're playing soccer or basketball, where you're coordinating with this team. How ready is our entire provider community to play what looks like a fairly different game?
Yeah. I think that, they're in different states of evolution. It's interesting. In some cases, there is a generational divide, and that some older physicians who are used to practicing the way they practice and maybe, a decade or less to retirement have said, I want to keep practicing that way. But mostly both the younger physicians and the older physicians that have come to see it really like it a lot better. I mean, they actually see they can spend more. So these chronic patients, another thing, you cannot have a 10-minute visit with a patient who's on 8 to 9 medications and has multiple chronic illnesses. They have cancer and depression. They have serious arthritis and asthma. You can't manage those patients in 10 minutes. And so once they see that they can be, again, liberated from those kind of 10-minute office visits, they do like it better. They see the value of their nurse practitioners. And this has been going on in pediatrics for 20 years, and it needs to happen more regularly in adult medicine. So I think it's in a stage of evolution. What Governor Shumlin talked about, having the data at the fingertips. Some practices are wired, some are not. Although we shouldn't. It is important, though. We have some rural practices that are not yet wired that are performing fabulously in our new payment model, through other means. So I think the teams are really being embraced and enthusiastically.
I would just offer my observation. I agree with Andrew. I think it is very different in different communities across the country right now. I think there are certain places that are both culturally, from an infrastructure standpoint, and from a formal sense, the way that the providers aggregate with each other or relate to each other is very, very different community by community. And that's why part of the reason why I think we all agree that there's no single solution that'll work everywhere. It's going to require some differences in local markets.
Governor Herbert, go ahead.
Well, thank you. I appreciate that the water cooler topic of the day in most states is health care. And Bill, you said it's an exciting time in health care. I guess that's the understatement of the day, because I think it's become very, and has been very divisive. It's a complex issue, and we appreciate, in fact, you're coming here to shed some light on the issue for all of us. I come from a state in Utah that is generally considered a healthy state, one of the healthiest in America. We have been rated as the lowest cost for health care in America, with about the 5th rated best quality. So we're doing pretty well. We're below the national average in those who don't have access to health care. And of those that don't, half of them could if they chose to, but choose not to for whatever reason. And so the concern in Utah is that as we have this kind of overall mandate to do something different, that we'll go from a really good system to the average. Those that are at the other side of the spectrum with high cost and lower quality are going to say, hey, this is good, we're moving the average, moving in the right direction. In Massachusetts, you're grateful that you're slowing the rate of growth of the highest cost
Right.
health care in America or the world. And we don't want to be at that high
Right.
end. So my question for all of you is really kind of the simple basic philosophy. I think we all share the same goals, although I think we don't define the goals very well. Is the goal for healthcare reform in the future to reduce the costs of healthcare? Is it to improve access to healthcare? Is it to have better quality of healthcare? Maybe it's all of the above, maybe additional things. Where we disagree seems to be, and the divisiveness is how we get there.
Yeah.
What is, in fact, the process to get there? And as I look at the history of America and our tradition of a free market system, free market competition, individual choice, and making those decisions coupled with individual responsibility, some are concerned that we're moving away from that.
Yeah.
And so why, if we think historically that free market competition, individual choice, and opportunity has given us the best products, the best service, and for the most people at the lowest cost, why do we seem to be moving away from that and think that somehow in healthcare it's a different animal? So that's a philosophical question. I'm anxious to hear you
Right.
all.
Well, Governor, shall I? Sure. Governor, it's the question of the nation right now, so you put it really well, and I have a couple thoughts of it. First of all, you're right about all the comparative information, and some of the reasons why Utah is so successful is that they have systems like the Intermountain system, which was one of the early adopters of some of these practices, the integration we're talking about, and obviously had one of the first exchanges in the country, though it was a private market-oriented exchange. When the ACA was passed, I think it anticipated a kind of uniform national set of standards and activities that the nation would adopt. And as a result of the Supreme Court decision, result of actions by individual governors like yourself and others, we actually were going to end up with probably 5 or 6 flavors or variations of how the ACA is going to play out in various states. And I actually think that may be a really positive thing, because it allows for different models for different states that have different markets, different sense of what that balance is between private innovation and government involvement, different political cultures, and different delivery systems and beliefs in that delivery system. I think that state experimentation and variety is going to take us very far, and I think governors can take the lead in that. And that's why I said initially that the statements that our co-chairs said, coming from 2 very different states, but both showing extraordinary leadership in their states, is in some ways evidence that can work, and that state innovation, experimentation. And then to answer your first question, I think we do want all 3. I think quality and cost we combine and call it value, the best care at the lowest possible cost. We want an efficient system. You have a fairly efficient system today. Our system has a long way to go to kind of promote the kind of efficiency you've established. I do think, however, that getting people, we know that people who have coverage get better health. It's not just they have a card, that's important, but the card is just a start. It's actually getting them to better health, again, respecting individual choices that people want to make. So I'd say let the state experimentation flower.
Governor Sandoval? Or go ahead, Governor Branstad. No, okay.
A lot of the focus has been on changing the provider system, moving from a fee-for-service to outcome-based services that rewards quality and outcomes. We have set a goal in Iowa of becoming the healthiest state in the country, which from where we began, I guess 19th, and we're 10th today. But one of the concerns I have is I think the only way it works is if you get the patients to take, basically for people to take ownership of their own health. Instead of looking to their physician or their healthcare provider to have all the answers, to get people to make the healthy choices, whether it's not using tobacco products, exercising regularly, making good choices in terms of nutrition and all of that. and then trying to align the provider reimbursement so that it also rewards and supports that. But I guess I'd like your reaction to that. I don't think all of these efforts work unless you get a buy-in from the patient, and I think there are too many people historically have looked at it that I just look to my doctor for answers as opposed to taking ownership of my own health. And we're trying to lead by example and do a lot of things and get communities involved, and we have these blue zone communities, and we're setting all this focus on that. And I guess I'd like the reaction from the panel to that strategy that we are in the process of implementing. We're in, our goal is a 5-year goal to go from 19th to 1st, and we're I think about the beginning of the 3rd year of this.
Governor, first of all, I'm familiar with the strategy, and John Forsythe, my colleague, who's a colleague of yours, speaks very highly of both the commitment you've made and them. And we've looked at the blue zone carefully. Blue Cross Blue Shield plans like the idea of blue zones, even though we didn't invent them. You're absolutely right. You may have heard this before. The most expensive piece of medical technology is not a positron emission scanner, but it's a physician's pen, right? Because they're ordering all the tests that cost so much. And, I have here probably the least expensive piece of medical technology that's strapped to my belt, which is, a pedometer. And
we gave those out at Des Moines University when I was the president.
Right. And competition and all that. And so we need to engage patients at multiple levels. First, in their health, as it sounds like you're doing, and setting ambitious goals and getting people to participate. And both co-chairs talked about, tobacco, diet, nutrition, exercise. Those are all really important. But the second piece is, I think what you heard earlier, is how do we design insurance products that place some responsibility on the patients to think about their own care, and then how do we couple that with transparent public data that allows them to make choices, back Governor Herbert to making choices, and how do we steer patients or encourage them to choose high-value sites of care? And that's the advantage of so-called consumer-driven products, in which patients have some skin in the game, have some financial responsibility, and we know from the early results that when that happens, they make different choices.
I would also ask about health risk assessments. We're trying to really incentivize people to do health risk assessments so they know their own risk factors, and then they can work on those.
Yeah, and that's essential. And first of all, that's a big role for employers, especially large employers are embracing that in a significant way. Wellness at the work site is a really important setting. And you have to understand your own health before you can actually know what actions to take in collaboration with your physician or another caregiver. So you actually want the team, and we have one, I'll just briefly, program where we're actually paying the patient, the doctor, and giving incentive to small business owners together to promote the health of the, not big, 1,000-person companies. These are small 20 and 30-person companies. We find that it's that circle. If you get all three focused, aligned around health and wellness, that we'll start to see actions.
Yeah, and I couldn't agree more. I would just, to build on that with some specifics, I think in many respects, consumer incentives are actually ahead of incentives for the delivery system, where you have, let's assume you have the consumer that's empowered, they have some financial incentives to take care of themselves and their health. The issue is, in most parts of the country, the incentives for the providers are actually, in some respects, at odds a bit with the consumer incentive. And at minimum, I would say there isn't an incentive for the provider, be it a physician or a hospital, to actually spend the time to equip the consumer with the information and the guidance that they can use to manage their own health. I mean, specific examples, if someone is at a hospital is being discharged, the hospital in most parts of the country today, many of them do it out of just the general goodness of their hearts, but they're not really compensated to spend time helping that patient understand the medications are on, make sure they're going to go get back with their patients at our medical home or their care team. And so in many respects, what we just need to do is catch up a little bit with the consumer incentive part of it, make sure those two things are aligned.
Governor Sandoval.
Thank you, Governor, and really appreciate your presentations. I was listening to Gary's comments about Utah, and that's very impressive. Nevada's in a little different position, and we made the decision to opt in with regard to the Affordable Care Act, and we work 49th in the country in uninsured. We're going to be adding 300,000 insured lives within a year. And so that's an immense amount of people that are coming into our healthcare system on a regular basis, many of whom have chronic diseases, about a lot of the things that you've talked about. And as we look, I feel like we can bend the curve with regard to utilization and healthier living, but the place where there's going to be a challenge is bending the curve with regard to healthcare costs. And I'd like to hear kind of your thoughts and observations with regard to those costs, because again, 80% of these lives are going to be in care management or managed care in Nevada. I'm trying to do everything we can to do that, implement those wellness programs. We're putting these little these bands on to pass those out so people are living healthier. But again, as I look at what we're facing in terms of costs for that, I don't really know what to do. And so I'd like to hear your thoughts.
I'll tell you, that's such an easy question. I'll take it. It's incredibly difficult, right? That is, in some respects, the challenge of the Western world right now, frankly, how to control healthcare costs. I think the truth of the matter is no one really understands the full answer, but I do think a couple of the ingredients there's reasonable consensus on and can be a helpful start. In many respects, the activities that both Andrew and Bill described, as well as in the States, I think are great starting points. I think some of those ingredients include, I think what most people believe is that there's both an opportunity to reduce some of the inefficiencies in the current system, but I think most people also believe that to change the actual rate of growth, it's going to require some more permanent changes, especially in the payment and incentive system, because there's some things you can do in the near term, care management programs, things like that can reduce some of the costs in the near term. But to really get costs to change over time, you both have to change how consumers think and behave. You have to think a little bit of that, change a bit of the health of the population overall. And then you really need to create long-term incentives for stakeholders, healthcare providers, others, to be inventing new ways to do things better over time. So that really requires, that's a longer-term challenge, but I think that requires not just short-term changes, but kind of permanent changes in how we pay for and reward healthcare.
If I can just add a couple thoughts there, because we're really trying to make some advances in Vermont on this. In plain English, when you look at big picture, what's happening across all of our states in varying degrees, we're spending more than anyone else on healthcare in the world for less good outcomes. That's what we sometimes don't talk about. We live less long than the countries that spend a lot less than us. We have higher infant mortality than the countries that spend a lot less than us. And we continue to have healthcare costs rise at rates that are higher than our incomes. So, since I believe that money drives America, that's what we do best, we're the best entrepreneurial place in the world, you've got to bring your providers around to the thought that they can do better financially with a different payment system. And I fundamentally believe that that's true, and that when they actually sit down and work it through, they realize that's true. Now, maybe it's different in urban states, but in my little rural state, most of my hospital administrators and providers believe that the current system isn't sustainable. That's kind of a big one. We're not talking about the corner grocery store going out of business or the dry cleaner around the corner. We're talking about our healthcare system. I had an experience a few months ago where I go down to the southwest part of my state. My hospital administrator down there is flipping out because the Monday before, the nearest hospital next to him, a big one, after 160 years of business, just said, we're out of business, we're done. So all of a sudden the folks, it was over the line in Massachusetts, so it's really, I thought at first it was Governor Patrick's problem, but then I realized they were having heart attacks, they were having strokes, they were having babies, they were getting cancer, and they had nowhere to go except to my hospital. So what we have done is put together, and this is really important, I think, what we call a blueprint for health, where we literally, in our small rural communities, we're giving this technology to the providers so that they're all getting on one uniform system where they can actually measure outcomes and integrate delivery with each other. The IT piece of this is huge. As they do that, they see that they can get better outcomes for less money for their patients, which we sometimes forget is what healthcare providers want to do. I mean, docs and nurses and the team are actually trained to make people better, not to navigate a complex payment system that we currently have. So I think the way you get the buy-in, and I think that Andrew pointed this out, is governors can't tell their docs and their providers, hey guys, we're all going to do this together and you're going to love it. What we can do is have a very deliberate and carefully designed partnership that allows us to facilitate providers figuring out that they can do what they love to do, which is make people healthy, in a payment system where they get rewarded for less quantity and better quality, and then measure those outcomes very carefully so that those who are doing the chronic care don't end up getting punished for a system that pays for less quantity and more quality. And it's doable, but you got to have those three pieces: the IT, the buy-in from the providers, and very measurable, agreed upon, measurable outcomes, so that you're improving quality as you spend less money.
Yeah, Governor Dalrymple.
Yeah, I have a question for Mr. Dreyfus. In my state, 85% of the health insurance coverage is provided by Blue Cross Blue Shield of North Dakota. Why can't I just tell Blue Cross that I would like them to offer the Massachusetts Alternative Quality Care Contract and save myself years of groundwork trying to develop something?
Well, first of all, you're going to get me in a lot of trouble by my colleagues. We have our great friends from Blue Cross Blue Shield of Tennessee here, and don't get any ideas, Governor, because they have their own innovations they care a lot about.
We were just trying to be nice hosts, but go ahead.
Right.
They're texting North Dakota Blues right now.
Right. Actually, Governor, it's not that far off, because the entire Blue system is working on a model, because the reality is that the model I described works great for the people who live and work in Massachusetts, but we insure a lot of companies that have people who work across the country, in North Dakota, in Vermont, in Tennessee, and we have to be able to link our payment model to payment models that Blue Cross Blue Shield of North Dakota and Tennessee and Vermont have. And so we are working on a national system that won't be identical to this, because again, markets are different and we have to respect that will link those two together. Having said that, I think this idea of, as a governor, setting a direction and pushing your, in this case, largest payer to accelerate their work around payment and delivery reform, I think is an appropriate role. And it's a role, you don't have to write a lot of new regulations. You don't have to create a lot of new agencies or government bureaucracy. You can say, I'm going to insist the private sector do it. And, I got some calls from my governor like that. And, I didn't like them the first time maybe, but we got moving. So I think it's, can I also respond to Governor Sandoval's question too? I just want to make the point to preach a little patience. We tens of thousands of Americans turn 65 every week, and they enter the Medicare system. And there's one thing we know that doesn't get written about enough. Some of them come in having insurance because they worked for companies, and some of them come in uninsured. Well, it wouldn't surprise you the ones that come in uninsured are more expensive for the first few years because they haven't been seeing a doctor and they've had these chronic conditions. But after a few years, they even out. So these 300,000 newly covered people you have in Nevada, some of them probably hadn't had insurance for years. And for the first year or two, they're probably going to be a little bit more expensive. And we learned that in Massachusetts. And don't assume because they're more expensive for a year or two that they'll be more expensive forever, because if we do get the right systems in place, we can then get the healthcare inflation down. So, there's going to be a lot of attention to premium increases in the fall in different states, and why is that, and how much is the ACA to blame, and I know we'll have a lot of debate, appropriate debate about that. But I think if we push these kind of payment and delivery reforms, if we focus on chronic illness and wellness and prevention and health, like in Iowa, you'll get the results you want, and your health status will improve, and your costs should not start to skyrocket.
Okay, we need to move toward rapid. Gary, do you want to add something?
Let me just, if I could just, I know you're going to close this off, but just make an observation and an editorial comment. I think everybody here recognizes, and Andrew, you're right, Utah did learn from Massachusetts with your exchange. We put an exchange in place which is a little bit different than yours. It fits more of our culture and our desire to get better health care in Utah. So we learned from Massachusetts. I hear some great things coming from Vermont here. I'm very concerned about the approach of a one-size-fits-all. And I think as a committee, one of the things we ought to be pushing is to give states the opportunities to find their own way with their own unique demographics, their own unique challenges that they have, which are all different. Utah and Nevada are similar in some ways and different in other ways, and so our needs are different, our challenges are different, and the solutions will be different. So let's make sure that we give states the opportunity to be these laboratories of democracy where we can learn from each other and probably gravitate towards a similar area. But we'll learn from our successes, we'll learn from our, I won't call them failures, but maybe they're not as successful, but we'll actually find that optimal place as a country and get to the place where we want to be for health care reform.
Thank you. I'm going to ask Governor Shumlin if you would make some closing comments on this.
Well, thank you, Mr. Chair, and thanks for your great work. And I want to thank our panelists and my fellow governors. You know, I actually think that Gary just gave the best summary that we can give, which is, you know, I think we all agree we're at a time where not much has happened in Washington, D.C. Governors actually have to make decisions and get things done. We work together in a bipartisan spirit to do that. I want to thank the NGA staff for putting this panel together. And I think, as Gary just said, we are going to be the laboratories for change in healthcare to improve quality, reduce costs, get better outcomes. And if we can use this forum and the conversation we've just had here as the fuel for that transformation, we're all going to win, and we can get this right. But I really do think it boils down to governors having the courage to work together with our partners to push where we need to pull where we need to, and to share common discoveries where we need to get this right, because it's critical to job creation, it's critical to quality of life, and we've got to find ways to reduce the cost curve where we're all dead economically in terms of what we're all trying to achieve, which is prosperity for the folks that elect us. So thank you, Mr. Chair, and thank you, panelists, and thank you, governors. I think this is an area where the NGA can really make a difference, helping us have the tools to be the laboratories for change.
I think what you just heard from Governor Herbert and Governor Shumlin is why we have NGA. Two fairly different states, two fairly different ideologies, as you said, but I think and two different approaches to ACA even. But I think you'd hear a whole lot more agreement than there is disagreement in terms of what the key issues facing us are. So I really appreciate that. I do want to thank our panelists. You guys are terrific and very, very helpful and practical and specific, and that's sometimes hard to do on a panel. So thank you very, very much. All right, before we break, we're going to have like about a 1.5 minute update from Frederick Assassi on the Center for Best Practices, and Frederick is there. Thank you very much.
Thanks very much. My name is Frederick Assassi. I'm the Health Division Director at the National Governors Association. This conversation was a perfect segue for what we wanted to announce to all of you, which is after the hard work of this committee and the Healthcare Sustainability Task Force earlier this year, one of the requests that came out of a GovZonly discussion was, is there a way for the center to work to give individual states the ability to move forward with the federal government and negotiate individual authorities under Medicaid around statewide transformation? So we've been working for the last few months to secure funding. We want to thank the Robert Wood Johnson Foundation, who's agreed to fund this project. And we will be announcing in the next week or so an opportunity for 3 to 5 states to come forward to work together to negotiate with the federal government new broad authorities in their Medicaid programs around statewide transformation. These are individual authorities for each state. So each state one size for that state, and not sort of a one-size-fits-all approach at all. The funding will allow us, we'll be hiring some leading national consultants to assist the states. We'll have an expert panel that will be working with the states and the federal government. We have received confirmation from leadership at HHS that they will bring their A-team to bear on this so that we can have really constructive conversations. So the RFP to states will be released in the next week or so, and then states will have about 6 weeks to respond. The launch will be in October, and we'll work over the next year with HHS, with the individual states, and with our experts to try to reach agreement in concept on new broad statewide authorities in Medicaid. And then I think one of the most exciting parts of this project is after it's over, we will be working very hard to basically build a template for other states interested in receiving these kinds of authorities so that we can kind of accelerate and move past the very laborious back and forth that we see so often in these discussions. So there'll be this template built, and then also a lot of discussions with HHS is there the ability to let states kind of jump ahead a little bit in the discussion so they can get to yes faster if they use these templates and these new processes. So very ambitious, very excited, and please, if you guys are interested, have your senior folks reach out to us, and let's get busy.
High stakes, high reward. We like
That's
it.
right.
Thank you. All right. I think, Linda, we good? Okay. I really want to thank everybody who attended, our panelists and the governors. This was a great session, very helpful, and thanks, as always, to NGA for making it happen. Thanks, everybody. We're dismissed. Good job. Well done. Very well done.